Thank you so much for joining us. This is Erin McLean. I'm the Assistant Director of the Center for Maternal and Infant Health at UNC. Today, we're going to provide the annual SIDS Counselor Update, and you're going to hear from Megan Kennedy, who's the Program Coordinator for the North Carolina Safe Sleep Campaign here at the Center for Maternal and Infant Health, and Rebecca Severin, who's the Program Officer for that project, as well as the county-level SIDS counselors, and she's with the Women's Health Branch at the Division of Public Health. Just a couple of housekeeping things. The audio is solely through your computer speakers. If you have questions along the way, feel free to put them in the chat box. If you're having trouble hearing a presenter, also feel free to put that in the chat box. We will take a brief break between Megan and Rebecca's presentations for a couple of quick clarifying questions, if there are any for Megan. Otherwise, and then we will, at the end of both presentations, have a little bit of time for kind of broader questions. So great. Megan, you want to take it away?
Sure, I'd be happy to. All right, well, thank you, Erin. And like she said, my name is Megan, and I'm just going to briefly go over our training objectives for today. So upon completion of this update, participants will be able to do the following. Define sudden unexpected infant death, which is SIDS, and sudden infant death syndrome, or SIDS, and other sleep-related causes of infant death. To be able to describe state trends regarding sleep-related deaths, to identify local and national resources available, to discuss the protocol for serving as a SIDS counselors, to enhance the support offered to families who have experienced the death of an infant, and lastly, to describe strategies to practice self-care. So I'm going to try to move through mine fairly quickly as I can. I really want to leave enough time for Rebecca to go through her information. I have a feeling you guys are going to have a lot of questions about that. So moving on to the next section, which is facts about sudden unexpected infant death. And this is likely going to be a review for a lot of you, so I appreciate you listening in. So sudden unexpected infant death, or SUID, is the death of an infant younger than the age of 1 that happens suddenly. So after a full investigation, SUIDs that occur during an unobserved sleep period may be diagnosed as one of the 3 types of SUIDs. So the first would be sudden infant death syndrome, or SIDS. The next is accidental suffocation and strangulation in bed. Third is undetermined or unknown, and these really take up the bulk of what the deaths are usually classified in, is the undetermined unknown, and this is because the investigation is really complicated. It's really hard to often make a diagnosis, and so often they are lumped in this last category. And I just want to highlight that these types of deaths, when combined, is the 3rd leading cause of infant mortality in North Carolina, and is the top cause of infant deaths for ages 1 to 12 months. All right, so SIDS, as you are probably familiar with, is the sudden infant death of an infant younger than 1 that cannot be explained even after a full investigation, and this investigation includes a complete autopsy, examination of the death scene, and review of the clinical history. It's important to note that in North Carolina, if a sleep-related infant death was associated with an unsafe sleep environment, which includes bed sharing, it would not be classified as SIDS. So we point that out because that's not universal across the country, and that's fairly new for North Carolina's classification. I believe that change happened around 2011, 2012. And bed sharing is when an infant sleeps on the same surface. That could be a bed, couch, chair, with another person, and that person could be a parent or a sibling or a caregiver. And so this is something that is often referred to as co-sleeping. I know that the medical examiner's office uses that term, so you might see that sometimes within this presentation. Okay, and then another classification is accidental suffocation and strangulation in bed, and this is a cause of death code that is used to identify infant deaths that are caused by suffocation or asphyxia in a sleeping environment. So this could be suffocation of soft bedding, could be an overlay if a parent were to roll over onto a child. It could be a wedging or entrapment if the child became stuck between the bed and a wall, or strangulation if there was something that was keeping the child from being able to breathe. All right, next we'll go through the North Carolina infant death trends and statistics in sleep environments from the years 2012 to 2016. And I wanted to thank Carrie Robbins. She created these slides. She is the Chief Fatality Researcher for the North Carolina Child Fatality Prevention Team through the Office of the Chief Medical Examiner. So thank you to Carrie. So first I wanted to point out, I think something might have gotten a little cut off here on these slides, but this is a graph showing, again, these deaths from 2012 to 2016. And what I really want to highlight here is that you can see that the large majority of these deaths are being classified as undetermined and unknown. And then after that, they are being classified as accidental asphyxiation. And then you can see in the green that the smaller number of these are being classified as SIDS. So even though SIDS, it's a tragic death, it's really something that's important to show that it is smaller compared to these other classifications. I think often we call all of these deaths SIDS without really better understanding that the classification is different and how they occur is different also. And moving along, this next slide is showing where, the association of these deaths that are accidental asphyxiation and undetermined, and how they are largely, I believe, 100% associated with some type of unsafe sleep environment. So you can see that an unsafe sleep environment, and what I mean by that is that could be something like a blanket being in the crib. It could be the infant sleeping in a place that's not safe, like an adult bed. It could be the infant having a hat on when they sleep. So it could be sleeping with another person in an environment. So all of these deaths are associated with some form of unsafe sleep environment. And what I really want to point out is that you can see in the blue that of these, all of these are associated with unsafe sleep environments. The ones in blue are associated specifically with bed sharing, or as they're referred to here as co-sleeping. So this is really what's driving a lot of these deaths, are that they are associated with some type of bed sharing. All right, next, Carrie took this data and zoomed in a little bit more to better understand where these deaths are occurring. So these, again, would be deaths that are not SIDS specific, but these are related to some type of unsafe sleep environment. So we see that the large majority of these deaths are occurring when an infant is in an adult bed. And then we can look further and see that of these deaths that are occurring in an adult bed, the majority of them are occurring when another adult is in the bed with the infant. So we know that there's no 100% way to bed share, but we know that there are certain infants and factors that do put an infant at higher risk of death when bed sharing. And we at Safe Sleep MC are really working to tailor our message to address these higher risk factors and populations. All right, next we see some the number of sleep-related infant fatalities by age, and again, this is from 2012 to 2016. These deaths do not include SIDS deaths. The majority of those deaths are, as you are probably familiar with, occurring between the months of 1 to 4 months. And again, most of these deaths that are classified as undetermined or by asphyxiation are also occurring really in those earlier months. And the reason it's really important to highlight that is that it really drives home how important it is for these parents to get prevention information to better understand how to create a safe sleeping environment. And so we really, think that this should be happening during prenatal appointments, during the hospital labor and delivery period, and then throughout, postpartum visits and well baby checkups and things like that. So they really occur much earlier than later. And lastly, this is just a summary that Carrie created that really just breaks down the fact of how many of the deaths that have been investigated by North Carolina, 969 deaths during this period, how the majority of these are related to some kind of unsafe sleep environment. That's 544 of these deaths, and 94 of these deaths were classified as SIDS. So, and if we look further, again, we see that most of these deaths are associated with an unsafe sleep environment and specifically associated to bed sharing and specifically to bed sharing within an adult bed. Okay, so that's the really bad news, is that these deaths are occurring. It's something that really has plateaued. We know that in the 90s when the Back to Sleep campaign came out, there was a major drop in the incidence of SIDS, but we really haven't seen a decline since then when it comes to SIDS and other sleep-related infant deaths. So through the Safe Sleep NC campaign, we are really motivated to help prevent these deaths. And we are working on a few different initiatives, and one of those is the Safe Sleep NC Champions. And what that is it's a goal to have this message of creating a safe sleep environment, going out to all corners of the state, and by doing this through really a grassroots operation by working with people in health departments like yourself or different organizations to really help disseminate this information. And we have different ideas of how to do that. And I did want to note that participation in this is completely voluntary. You might be a current SIDS counselor. That does not mean you have to serve as a Safe Sleep NC champion, but we do just want to let you know about it because we are definitely interested in building this up. And if you or someone else you know within your agency would be interested, we would really like to talk more to you about that. So our goal is to really get this message out, and how we plan to do that is for everyone who's interested in being a Safe Sleep champion, for them to take an online training and for them to utilize the resources we have and to tell people about the resources we have, and also to really work with our e-toolkit that we're creating. And so this would, you don't have to be tech savvy. It can be as easy as, clicking share or something like that within your social media platform if your organization has that, to get out these different messages. So in addition to working on the Safe Sleep Champion program, we're also working on a new website, and the website is designed to be more interactive for parents to be able to come and take quizzes and games and to better understand, what it means when we talk about safe sleep, and really to help support them. We know that nighttime parenting is incredibly challenging, and it's really a place to support them and, not so much tell them what they should do and what they're doing wrong, but really to help support them to make the best choices they can and to reduce the risk and to have a safer sleeping environment for their babies. So next, I just want to share with you some resources that we have for providers and clinics and for parents and for caregivers. So first, if you click on here, there's a list of support groups for parents and families who have experienced the death of an infant. So when you're out and you're, in your role as a SIDS counselor, this might be an important list to have handy. Some of them are national. Some of them are something that can be web-based. Some of them are very much local to different parts of the state. So I would encourage you just to have that as a resource for when you're working with bereaved families.
And
Also
I just
wanted
to
to
say,
yeah.
a PDF version of these slides are available in the file pod at the top of your screen, and you can download that. And all these links are enabled. So within the PDF, you would be able to click and go to those links.
Perfect. And this is a online training we have. It's free. There's 1.5 nursing contact hours that go with it, and it's really just giving a more in-depth view about safe sleep, more information about the state data that we have, national data that we have, and really going in to a lot more detail about how to engage parents, how to have honest conversations, how to support them, to make the best, safest choices they can. So like Erin said, that is available to take there at that link. You can also always go to safesleepnc.org, and we have resources there. This is a flyer that you may or may not be familiar with. All of these are free, and I'll tell you how to get them. This is a front and back flyer. It's focused on some of the key questions that parents have and really just the key safe sleep information. So if you're working with parents, we encourage you to, not just hand this to them, but really talk through and see what questions they have and engage them in this way about safe sleep. We also have posters that are available. Some of them are general, some of them are specific to, reaching out to those older caregivers or grandmas who might be caring for baby. And all of these come in English and Spanish and are also free to order. And to order them, you would go to the Women's Health branch. This is the link. You would go to the publications form, print it. It's old school, so you print it out, check out what you want. You go to page 3 under the parenting and baby, and then you can fax in your order, and it will appear at your door shortly after you put in that order. So the flyers and the posters are available to order through this source. And next, I just wanted to quickly go through some national resources that are available. If you want more, there is more out there. I have heard that it's often out of stock, but that isn't always the case. But if you go to the national site for Safe to Sleep and go to the campaign materials, they have a really wide selection for different populations, you can have a flyer, a brochure, and also there's information in there specific to providers that are free to order. Next is just wanted to share with you the Consumer Product Safety Commission website. They have lots of videos and discussion and posters about a safe cribs and what is a safe sleep environment when it comes to cribs and bassinets and places like that. And I told you I'd be quick because I wanted to leave lots of time for Rebecca, and this is my contact information. We are really excited about the work that we're doing. We have a advisory group that we convene every quarter and discuss how to better work with the state and how to get this information out and to help really prevent these deaths. And if you would like to join in or if you have questions, I would welcome you to reach out and contact me and find out how we can partner. So that's it from me. I know that was quick. If you have any questions, I can take those now.
I haven't seen any yet in the chat box, so let's go ahead and let Rebecca present, and then we will ask for questions again.
Sounds great.
Okay. Hello, everyone. Again, my name is Rebecca Severin, and I'm the SIDS Program Manager with the Women's Health Branch. It would be helpful if I forward my slide. Okay, perfect. So the second part of this webinar is going to focus on details specific about serving as a SIDS counselor. So some of this information may be a review and a refresher. Some of it will be new information, but I hope that it's all helpful. So let's get started. So of course, the process begins with the notification of an infant death. Those notifications are received by Lisa Mayhew at the Office of the Chief Medical Examiner within the Division of Public Health. She sends these notifications of infant deaths that they meet the statutory requirements. So usually they are of unknown reasons why the infant has died. and most of the time it's sleep-related. As Megan shared, sleep-related doesn't always mean SIDS related, and so, of course, there's still an autopsy report that has to be completed for that to be determined. So these are deaths that occur of infants, so that's just from 0 to 12 months of age, and they come through, like I mentioned, the Office of the Office of the Chief Medical Examiner, and they are sent to me here at the Women's Health Branch. So the information is then logged in a spreadsheet that I maintain at the Women's Health Branch, and I track all of these cases. And so then the information I receive is forwarded to the single point of contact at the local health department. So that's someone identified at the each of the local health departments that has that either are SIDS counselor themselves or they supervise SIDS counselors. And so they are my single point, so that way that communication is kind of consistent. So the information that we do receive is very sparse from the Chief Medical Examiner's office. It includes just the infant's name, the county, the pathologist's name, and sometimes the date of death and date of birth if Lisa Mayhew can obtain this information. And so then I send that via email notification, and I try to add some context to it. So, of course, I include next steps that can be taken, as well as like the autopsy link. So it's definitely important to know who your single point of contact is at your local health department. The next slide is just an example of what it looks like. So as I mentioned, the body number actually is a number specific to the Chief Medical Examiner's office. So that's not something that we actually use, but we only really get a sparse amount of information. Sometimes, depending on the county, Lisa Mayhew is able to provide the date of death and date of birth for the baby, and if I do have that information, I will send it forward. And so because of that, because of the notification, it's usually very sparse, there is some discovery needed. But before we get to that, there's a second way that cases do come to our attention. So that's through you all at the local health department level. So this is just through the local community, so whether that be information from EMS, from obituaries in the local newspaper, other programs within your local health department, as well as funeral directors, etc. And so, of course, if you become aware of a sleep-related infant death that you've not already been informed from me here at the Women's Health Branch, please let me know of that as soon as possible. So that way we can get pertinent information, the condolence letters out to the family as needed, as well as I can then support you all with that. And then, of course, we can do the tracking as needed on our end. And so, of course, when you all do know that information, that would be great. So on to the next slide is what follows notification. So I alluded to the fact that there is a bit of discovery needed. So it is a requirement of the local SIDS counselors to utilize local resources to identify the caregivers of a deceased infant. The best first steps is to contact vital statistics for the death certificate, and then to follow up with other programs when applicable within your local health department. These other programs can include child health clinics within your local health department, CC4C, pregnancy care managers, and then, of course, any resources that you have outside of your local health department, like any relations with funeral directors, EMS, etc. And so, of course, we ask that you all practice due diligence, which is every effort to discover further information about the deceased infant's family is utilized. In some cases, you may need to leave your contact number with service providers. For the most part, you won't have any release of information. And so you might just have to do that, leave your information, ask them to share it with the family when they come in contact with them again. So that way you're waiting for the family to reach out to you if they're interested in services. In other cases, we'll have some families that are virtually invisible to community resources. It's like no matter what you do, no matter what avenue you try, you just are unable to obtain information about the family, and that's okay. What I ask is that you guys just document on the home visit contact form all the efforts you made, and then you can call me here at the Women's Health Branch, and we'll just go ahead and close the case until pending further information on the family should we receive it or not. But there is only so much that you all can do. So next, what I mentioned, of course, is once the counselor obtains the information about the infant family, so that's name and address, if you would please share it with me as soon as possible. If you're at the Women's Health Branch, that does trigger me to send a letter of condolence to the family. In the letter, I identify who is the SIDS counselor that will, or the contact that will be getting in touch with them, as well as some resources. In the right corner, you'll see some of the resources that we do provide to families, some pamphlets about understanding grief, some information related to healing grief, as well as other resources. And so when I do send that, I also send out a letter of resources to the actual, the letter to the actual counselor. In it is really a refresher. For a lot of the counselors, you all can contest that it sometimes can be weeks to months in between cases, and sometimes from the time you do your basic training, it can be 6 months to a year before you actually get your first case. And so I'd like to be able to send out that letter as well as the memory ring, so that way you all have that. And so please don't wait until you find who the family's information is to let me know who's going to be the lead SIDS counselor on the case, because I can get that resource out to you beforehand. And of course,
came up about Spanish language materials. Are any of these resources available in Spanish?
Yes. I'm sorry. Yes. So we do have, for all of them, we do have Spanish resources. So that's just like information that when you do know more about the family, if you just let us know if they're Spanish speaking, if they're teen moms, if the grandparent is the primary caregiver, we have resources that kind of meet the needs for different types of families. So thank you for that question. I didn't mention that. So I'll take a minute just to answer Lisa Manning's question since it's pertinent to this part. So yes, if it's a death notification that you all are particularly sleep-related deaths, because as Megan showed that there's not as many SIDS deaths as we are receiving, and of course we really don't know what the cause of death is for any of the families you all get notification from for my end. So if there's a death, and you might even know that it's suspected to be a bed-sharing death, still notify us here at the Women's Health Branch. Those are deaths that we still track because those are the same types of deaths that we're getting from the Chief Medical Examiner's office. So hopefully I cleared that up. But again, I'll just continue. So of course, outreach and service provision, we all kind of know what that looks like. It's the initial home visit and then the follow-up home visit where the autopsy report is discussed. But we also know that there's more to the services that we need to be mindful of. Supporting families that are experiencing bereavement needs to be treated delicately because it can sometimes be daunting. So what we're next going to talk about is some tools, techniques that I hopefully can bring to you all about supporting bereaved families. Okay. So, see what I got.
Becca, before you jump into that, we also had a question. Do you still get involved as counselors for the family if it is a co-sleeping death and is not categorized as SIDS?
So, yes. Let me make sure I answer this correctly. So a lot of the deaths that are received from our notification process that we get from the Chief Medical Examiner's office, I would say the last maybe 30 deaths that we received, there's been a substantial amount of them that have actually come out to be co-sleeping deaths. It's because we don't know that yet. And so I'll talk a little bit later on about how we want to present our cases to families and not actually identify ourselves as SIDS counselors, or because it can give the connotation that we're giving a reason for the death, and we really don't know that until it's been determined by the autopsy. And so what we are finding ourselves is that we are getting a lot of deaths that are actually related to unsafe sleep practice. And so in that regard, we want to still treat them as a bereaved family and provide them the support when it comes to grief support, regardless of if it's SIDS or not. And that, in the next couple slides, I'm going to talk about what that will look like and what tools that can still be used to be able to provide that support, regardless of whether it's a co-sleeping death, a SIDS death, or it just becomes undetermined.
And once I can jump in, part of, we used to, in the past, before, the kind of official designations changed about what constitutes SIDS, what constitutes co-sleeping related, or a lot of these would have been lumped together as SIDS deaths, and then the data definition changed, right? But as Rebecca said, it doesn't really change from the family's perspective, that they are still a bereaved family, right? And so still need that support.
Definitely. Thanks, Erin. And so I definitely wanted to, definitely talk about how you all as SIDS counselors are in a very sensitive position. You are providing support to some families probably in the worst day of their life, or in the worst time of their life. And so that can be very intimidating, and not knowing what to say and how to say it can be daunting. And so, when you're bearing witness to grief of another person, it's stressful. And so hopefully I can give you some tools, techniques, things to say, things not to say, that can guide you in the right direction. So the first tool I want to share with you all is one that I learned through the Resolve Through Sharing training, which is a grief support program. And it's a tool called PRAM, P-R-A-M. And it's an acronym, and it's a tool that you can use when you're preparing yourself for an emotionally draining encounter. This is not only grief specific, but it was written and intended for dealing with bereaved families, but it can be used in any situation where it's going to be a high stress environment. So the first step is pause. So that means to stop and be still. You need to take inventory of yourself. Think about where you're holding stress. Unclench your jaws, unfold your arms, unclench your hands, roll your shoulders back, kind of get in the moment and focus on something in your environment that can draw your attention, just to get you present. Then you want to reflect, the next step, and that's to think about the situation that brought you to the encounter. Think about building rapport with this person that you're going to meet. Think about how you can kind of be your most genuine self in that moment. The next step is to acknowledge. Acknowledge what you're feeling. It's valid. That anxiety, apprehension, the fear of the unknown, of how this person is going to react to you, and so forth in that regard. And know that's okay, and name it, because once you can name it, you can kind of work through what you're feeling in that regard. And the last step is just to be mindful, to take the time and to think about what you're saying, to be deliberate in your speech, to practice silence, that sometimes you don't need to fill the space with words, and to pay attention. Sometimes we can focus in and have tunnel vision, but to understand that that individual that you're interacting might not be the only one in that room that's grieving for this infant's loss. So try to bring all of your senses into the encounter and just to remain present in that regard. So really the first encounter, the first form of communication that you're going to have with the family is via phone communication. So the first thing we want to do is, I mentioned before, instead of referring to ourselves as the SIDS counselor, this can be misleading. Of course, that's the official title of the program, but really to families, you guys can call yourself anything, whether it be a support person, whether it be infant loss support, whatever you feel comfortable with is what to use. And only because, like I mentioned, it can be misleading because it can sound like we're giving a cause of the baby's death, and we don't have that information yet. And then the use of the word counselor, I do know that we have some individuals who are SIDS counselors that actually can be considered a true counselor. They have the education and the experience to do that, but I don't want to put that qualifier on anyone and put that expectation. So if you're not a counselor, just to be careful in using it, and because you can give a false sense to the family of what's beyond your scope. And so I would just, like I mentioned before, use whatever is comfortable to you. And you can really, that can be whatever. The title can be anything to the family. Definitely when you're interacting with the family over the phone, you want to speak clearly and succinctly. You don't want to spend too much time opening up that grief over the phone. You want to definitely do that until face-to-face. And so I wrote here an example. You can use it, you cannot. But my name is Rebecca. I'm from the Women's Health Branch. I provide support to families whose babies have died. I want to know if I can provide the support to you and your family. It could be as simple as that. It doesn't have to be those exact words, but definitely you can use it up to your discretion. So of course, if you face indecisiveness from the family, you can always reassure the caregiver that no decision is needed at the time that you called them. But then I would also not leave it in their hands to call you back. Just let them know, hey, I will call you in 3 days to see if you're still interested. And, of course, keep your word. Do call in 3 days. Set yourself a reminder to just find out. And if they do refuse, just leave the door open that if they change their mind, if anything changes, they can contact you again. But we definitely don't want to put any pressure on families because people grieve at their own pace. And so we just want to be mindful of that. And so then the next thing we're going to do is just move into that initial home visit. So the first thing I want to kind of bring up is definitely know and use the baby's name. We want to honor that baby as a person and honor that family's loss. And so you definitely want to continue to use the baby's name just to show that you understand that this was someone important to that family and they had an identity. We want to maintain open-ended questions, allow them to tell you about their baby, ask them what their understanding of what has happened. That will definitely open the conversation up without feeling accusatory or feeling like they're being interrogated. And then, of course, we want to avoid providing a premature cause of death. So that's something we mentioned before. You want to provide education to parents. So it's possible to say something like, while it is too early to determine what your baby passed away from, here are some possibilities. And then you can go into being prepared to explain SIDS, other sleep-related causes of death, and then the possibility that there might be an unknown reason. But that just opens it up so that way they understand that what the options could be. Avoid saying, I understand what you're going through. I put here unless you have firsthand experience with grieving an infant loss yourself, and even then I would just be cautious of this. And I say that because it can sometimes, even though you've been through an infant death, everyone's grief process is unique, and its relation is to its relatives, and it's incomparable. And it can be sometimes seen as kind of like a Me Too type of thing. Like, I've done that. I've been through this too, so it can kind of minimize what the person's going through in that, and putting expectations on how they should react, feel, and it kind of puts parameters on how someone should feel. So I would definitely err on the side of caution if you do have first-hand experience, and definitely to avoid the language of I understand if you've not gone through that firsthand. The next thing is to utilize active listening, paraphrasing, definitely by restating what the parents have shared, reflect, using language like what I hear you say, use clarifying techniques, which is I want to make sure I have a good understanding, as well as summarize at the end of any encounter with the family, what was discussed, highlight next steps of the counselor and then of the family. And definitely use silence as a tool. I mentioned that before when we were talking about PRAM. Silence can be a very effective tool in getting a person to open up. Definitely don't feel like you need to fill the space with words. Sometimes you can sit back and rest and let the family then open up about what they want to share, what they don't want, and let them lead the conversation in that regard. And then one thing I put in here to remember is that, and to be mindful, is that in a crisis, parents really only hear 10% of what someone shares. So be careful of giving them too much, of overloading them with information. I know, of course, during that initial home visit, we are explaining what the different options and possibilities are of the cause of death, that's SIDS, sleep-related causes of death, and what would happen if it's an unknown, or why could it be an unknown. Maybe share some information and maybe follow up with family later, or you can provide some reading material with it, so that way they can read these things at their leisure after the home visit. But just to be mindful that at that time you don't want to be giving an overload of information, because the odds of parents being able to absorb it all is very minimal at that time. And so the next slide is just other phrases to avoid. Here is God's will. Of course, we want to be mindful of bringing God into the conversation, because we don't know what the religious background of the family is, and even if they are of a religious background that identifies with God, just to be careful of that language. It can come off as very insensitive. Time will heal. That's another one. We're kind of putting parameters in someone's grieving process. Some families will never get over this death. Can have other children at least, and your baby's in a better place. These all can have that same connotation as minimizing someone's pain. So we just want to avoid these phrases at all costs. The next advice is to not complete the contact form in the presence of the family. It can just come off as very impersonal. It's best to maybe have a small notepad and explain to the family that specific dates or specific names that you want to write down so that you don't forget them. But it's best to be familiar with what the form is asking for before you have the encounter with the family, and so that you can bring to your remembrance some of these things versus actually filling out a form in the presence of the family. To be mindful of your body language. So, of course, crossed arms, hovering, looking everywhere but at the person that's speaking with you, sometimes overuse of eye contact, furrowed brows. All of these can be very, can give the wrong impression of what you're there for. So just be careful that you're not closed off in those regards, and as well as the best practice is really to mimic the position of the bereaved. So if they're sitting, it's best for you to sit. If they're standing, it's best for you to stand. Not to hover over them, maintain appropriate distance from them without being across the room and things like that. So there is that. I'll move on to the next slide. So follow-up with the follow-up home visit, excuse me. So prepare the caregiver for the wait. We are seeing longer and longer wait times for the actual autopsy report. There's a lot of reasons for that, particularly, with the opioid epidemic that's hitting all 50 of our states. There is priority given to some of those deaths, homicides that unfortunately our little babies aren't always at the highest priority. But it is possible to get preliminary causes of death, and this could be obtained with the pathologist's name, and they have different regional offices. So if anyone is waiting for an autopsy report, please, I'll have my information at the end of my slide presentation. Please reach out and let me know, and I can follow up with you if I can find the pathologist's name. I can give you the contact information for the office, and then you can call, and they're really good about giving, and of course identify who you are, and then they're really good about giving preliminary causes of death. So definitely feel free to follow up with me if you are still waiting for any autopsy reports in that and that. What is next? As Megan shared, with the increase of unknown and undetermined findings, it's something to do specifically with our state and how they're classified. So it's best to be prepared and maybe to prepare the family, and that there's a possibility for it to be unknown and undetermined findings. And do that so that way there's not so much surprise if it comes back, particularly if they've been waiting for all this time and it still comes back undetermined. That can definitely be daunting to families. Okay, so what I did want to touch on while we have the time together is some safety and self-care techniques. I'm sure you guys have plenty of questions for the other information I shared, but I did want to give time to talk about some of these things. So of course, it's always the most important thing is that you practice sound, safe care of yourself when you're doing any type of home visiting. So that means letting someone know when you're going to be away from the office, where they'll know what the address is. Of course, when you get there, if there is, the apartment complex, which is a huge crowd of people, feel free to call the caregiver and let them know that you would like to reschedule. Definitely don't park your car in a place where it can be easily blocked in, so avoid driveways. Try to park as safely as you can on the street curb, so that way when it's time for you to leave, you can leave without any obstruction. It's okay to ask if someone else is in the home, or even before you get there to ask, will there be anyone else in the home? Always know where your exit is, and don't allow your back to be towards a door. There's a really good video that I've linked here. It's provided by the Oregon Public Health Division. It is a YouTube video, so like Erin mentioned, of course, it's going to be live on the slides that's shared. But of course, if you just wanted to put in this name into YouTube, you could find the video there as well. It's important to debrief with your supervisor after encounters with bereaved families, just to be able to get that off of yourself. To be able to share that information with someone else can kind of help you put it in perspective. And if you don't do and it helps you not be so hard on yourself, definitely be kind to yourself, and because there's no right way to support every bereaved family, which is tools and techniques that you can use in the situation. And so sometimes it's going to come off as, yeah, that wasn't the best that I could do. But it helps you debrief with another person to not be so hard on yourself when things like that happen. Of course, maintain boundaries. When we see people in pain, particularly when we are in giving fields and serving fields, we can sometimes take on other people's pain, struggles as our own. And so a couple questions that I always ask myself when I'm putting positions of whether I have to think about boundaries is, would you document it? 2, would you tell your supervisor about whatever thing you're going to do for family? 3, can you do it for all of your families, all the families you encounter, whether they are bereaved or not? Is this something that you could provide? And then 4, is it an expectation I can put in my coworkers? Because, of course, it's very important for us to have continuity of services when we're providing a service to the public. And so if I do this for this family, is it something that I can expect my coworker to also do for that family? So those kind of keep you honest about your boundaries and what you can and cannot do for families. Engage in whatever your own spiritual, religious activities are is definitely appropriate. Dealing with an infant, in most of our cultures, infant death isn't natural, and so that can sometimes, we can hold on to that feeling. And so it's important to engage in whatever spiritual or religious outlet you have to be able to kind of come to terms with that, as well as adult healthy outlets. So whether that's yoga, exercising, for me, I like ASMR videos on YouTube, any of those things. to be able to kind of de-stress yourself and to lay these things at, pretty much take them off of you so they don't bleed into your personal life and cause all types of havoc in that regard. So that's really all I have for you all. I see there's like a ton of questions that have come up.
A couple of questions for you. Thank you guys both. It was a really great presentation. So I'm just going to take them in the order that they're here.
Okay.
We had one question from Susie Hess asking, I had a patient whose baby died at the hospital due to prematurity. Should I have contacted you all about the death? The mom was linked to counseling services.
Gotcha. So in that regard, no. These are particularly deaths that happen, I want to say, for the most part, these deaths are deaths that happen at home. I guess there is a possibility that a child could be at home and, it could be a strangulation of some sort, and they didn't die at home, but they maybe died on the way to the hospital. That's different. If this child was premature and in the care of healthcare providers, the cause of death is because of the prematurity. The deaths that we want to know about are those particularly related to sleep. So SIDS, any of the, issues with the ASSB, any of those, and particularly those that happen in the presence of a caregiver. If you have any questions about it, please feel free to pick up the phone and call me about whether you find a death locally, you're just quite not sure. We can talk through it. I'm definitely here. My contact information is easiest to reach me by email, and then I can follow up with a phone call, or you can leave me a voicemail or a call. Sometimes I seem to always miss them as soon as I walk out of my office, but I'm available if anyone has a question about a death they know of and it's like just not sure if this qualifies as a death that's going to be to receive support through the SIDS program.
Okay.
Hopefully I answered your question.
If we have preliminary autopsy findings, should we do 2 follow-up visits, one with the preliminary findings and then one with the final results?
You can. I would leave that to your discretion and, of course, what the family would like. I think it's best to always go with what the family would like. So if you do have a preliminary finding and you share it with the family at a follow-up, at that point I would ask them would they feel better, is that something they would want, and then just go from there. But it's not a requirement. Of course, with the SIDS program, it's recommended that there's 2 visits, but in some cases, people have had more visits with families, particularly those having a harder time. So I would, a couple, of course, that wasn't a clear-cut answer, but first I would see what is best the family would want, and 2, what's the capacity for you as a SIDS counselor to do, because I do know you all have other duties within your local health department. So even if that is not necessarily a follow-up visit, but a follow-up letter, something, if the family would like. So yeah, I would definitely leave that to your discretion.
And that kind of gets at Darlene's question, which is if a parent asks us to come back and sit and talk and listen to with them, is that okay? Should we keep it at 1 visit and 1 follow-up visit? It sounds like it kind of depends on capacity, and that's maybe where there's an opportunity to lean on some of these community resources if you find that they need more intensive bereavement counseling.
Yes, definitely. But yeah, particularly I'm thinking about Darlene's situation in that, like Erin said, of course it's based on what your capacity is at your local health department. Definitely do not burn yourself out. Lean on those resources. But if you do have the time as well as the conversations, particularly, the need is appropriate for what you're doing. So if it's becoming that family just is attached to you, that's where I would definitely follow up with your supervisor about techniques on how we can best transition this family to another service. Sometimes it might be what they call a warm handoff. Maybe ask if they are interested in any further counseling, and then maybe at the next encounter bring that person that's going to provide that can't provide that service so that way it's, a warm handoff to the family so they understand, like, this is where our encounters end and this is where you can get further services. But yeah, I would just be definitely mindful of your boundaries there and that the family's not just getting attached to you because you were the one that responded to them in need.
We also have a question, if a family doesn't want to use this as a resource, what would you do? I know you talked a little bit about this, but do you have any other suggestions?
Definitely leave the door open in that they always could change their mind. I would ask them if there's any referrals that you can write, and then leave it at that. On our contact form, you just document that it was a refusal, and we would close the case unless the family asked to reopen it for some reason. But we definitely can understand that some people grieve in a way that they don't want. That's not the type of support they need, and that's okay. I see people writing.
Megan, do you want to just quickly evaluation?
Yeah, you bet. You all are welcome to still post some questions, but while we're waiting for people to post those, I did want to let you know about this evaluation. When we are done, you can click on this and complete this evaluation. It also serves as record of your county health department's participation. And we do also ask some questions, just so we have a better idea of what you would like to see next time in the update, things like that. And there's also a question, if you are interested in being a Safe Sleep Champion, to check that box and I'll be in touch with you. And even if you aren't totally ready to, commit, but you're just interested in hearing more, or you think you know someone in your health department, that's not, signing you up any type of commitment. So you're welcome to check that. And I just want to touch really fast, and I meant to mention this when I was speaking, that I know that the title has been SIDS counselor, and kind of like what Rebecca was saying, is that it really is much more broad than that now. I know in the past, before 2011, when we had a changing of the guards at the medical examiner, a lot of these cases would have just, like Erin said, been lumped in as SIDS, but really they're really doing much better investigations and finding out better answers of what's really causing these deaths, even if they go under undecided. We still have a better idea if they weren't SIDS, likely. So I just wanted to just kind of encourage people to, yes, we're called SIDS counselors, but maybe to just expand our idea of, that it's really about SIDS and any type of sleep-related infant death, and these are the families that we're serving.
And I just want, I'm sorry.
Go ahead.
No, I just wanted to follow up with what Megan said, of course, to add on to that if there's any questions in regard to anything when it comes to SIDS, this program, please feel free to email me. That's the easiest way to get in touch with me. If there's, and just to reiterate, if there's anyone that has had a case sitting on their desk that they still haven't had an autopsy report for, please reach out to me by email, so that way I can try to get and determine who that pathologist is, and if we can at least get that family a preliminary cause of death. And that's it for me.
Well, thank you both so much. I don't see any other questions coming in, so we're going to end this webinar. It will be archived and posted at safesleepnc.org, so if you need to get back to it, as well as the PDF slides will be posted there as well. Thank you both. Hope you have a good day.